Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this session, I will be discussing a very important topic in the pulmonology, that is the respiratory failure, right, which is also a very important medical emergency. And this respiratory failure, it is one of the most common reasons for the ICU admissions of the individual. And almost like more than or equal to 75% of patients, they require mechanical ventilation during their stay in the hospital in patients with a respiratory failure. Now, this respiratory failure, it is categorized mechanistically on the basis of pathophysiological derangements in the respiratory function. And accordingly, we have 4 types of respiratory failure. Right? Accordingly, we have 4 types of respiratory failure based on the pathophysiological derangements. That includes type 1 respiratory failure, type 2 respiratory failure, type 3 respiratory failure, then type 4 respiratory failure. So these are the 4 types of respiratory failure. Out of which, let me discuss the first one, which is nothing but acute hypoxemic respiratory failure. Right, acute hypoxemic respiratory failure. So that will be type 1 respiratory failure. Now, in case of this acute hypoxemic respiratory failure, you have to understand that there will be hypoxia, right? And if you take the carbon dioxide levels, they are normal or decreased. Right, carbon dioxide levels, they are normal or decreased. That is what you will have in acute hypoxemic respiratory failure. Now, why does this acute hypoxemic respiratory failure occurs? What is the basic pathophysiology? And that is mainly due to the alveolar flooding. Right, that is mainly because of the alveolar flooding. Okay, this is the basic pathophysiology for the development of the acute hypoxemic respiratory failure. Now the question is, this alveolar flooding, it occurs as a consequence of, right, what are the scenarios where you will have this alveolar flooding? You will have that in patients with the pulmonary edema and this alveolar flooding can occur in patients with lung injury, and this alveolar flooding can be seen in patients with pneumonia and finally in alveolar hemorrhage. So these are the conditions where you have the presence of the alveolar flooding, and due to which the exchange of oxygen does not occur, resulting in hypoxemia. And if you see this pulmonary edema, we have 2 forms of pulmonary edema. One is cardiogenic pulmonary edema, right, and the second one is non-cardiogenic pulmonary edema. Right, non-cardiogenic pulmonary edema. So if you see this cardiogenic pulmonary edema, this cardiogenic pulmonary edema, it is seen secondary to congestive heart failure. Cardiogenic pulmonary edema is seen secondary to mitral stenosis. And non-cardiogenic pulmonary edema is that you will see in patients with ARDS, right, that is acute respiratory distress syndrome. And in patients with non-cardiogenic pulmonary edema, you have to remember that pulmonary capillary wedge pressure, it will be normal. Right, pulmonary capillary wedge pressure will be normal. That is what you will have in non-cardiogenic pulmonary edema. Whereas in case of cardiogenic pulmonary edema, there will be elevated pulmonary capillary wedge pressure. right? There will be elevated pulmonary capillary wedge. So your cardiogenic pulmonary edema is elevated pulmonary capillary wedge pressure edema, whereas ARDS is low pressure pulmonary edema, right? Please remember, this is a very important point. And ARDS is a very important medical emergency also. It is called as acute respiratory distress syndrome. Why is that? Because it is acute in onset, right? The insult to the lungs will be acute in onset, that is within or equal to 1 week, right? So within less than 1 week, the individual can have the pulmonary insult or lung insult causing the development of acute respiratory distress syndrome. And in ARDS, it is bilateral lung, right? Bilateral opacities, right? Bilateral opacities on the chest radiograph will be seen. That is what you will have in patients with the ARDS. So the next question is, what are the clinical settings in which the type 1 respiratory failure occurs? So type 1 respiratory failure, I have said you one of the very important etiology is ARDS. And what are the causes for ARDS? The most common cause for ARDS can be sepsis. And the other important cause will be pneumonia, which can cause the ARDS. Then gastric aspiration, right? Then followed by that near drowning, and as well as multiple blood transfusion. Right? Multiple blood transfusion. So these are the causes for ARDS which can make the individual to develop type 1 respiratory failure. Then how is the mortality in patients with ARDS? See, the mortality rate among patients with ARDS is very high. Right? Mortality in patients with ARDS is very high. And all these patients, they have to be admitted in ICU and they have to be placed on mechanical ventilator. So if you see the settings of mechanical ventilator in patients with the ARDS, the very important settings is that if you take the tidal volume, we have to use low tidal volume for patients on ventilator with ARDS. And how much is that low tidal volume? That is 6 ml per kg. But if you take the PEEP, you have to use the high PEEP, right? That is high positive end expiratory pressure. So this should be the settings of mechanical ventilator in patients with the ARDS. Actually, there was a trial also, right? There was a trial in patients with ARDS by using large tidal volume and low tidal volume. Large tidal volume means 12 ml per kg. Low tidal volume means 6 ml per kg, right? So by using this particular tidal volume, the trial was done in patients with the ARDS. And this trial has demonstrated that when you are using the tidal volume of around 12 ml per kg, that has caused ventilator-induced volume trauma, right? That has caused ventilator-induced volume trauma. So that is the reason why the trials have said that you have to use low tidal volume in patients with the ARDS. And next thing is, in patients with ARDS, because they are placed on mechanical ventilator, in order to improve the patient ventilator synchrony, right? In order to improve the patient ventilator synchrony, neuromuscular blockade has to be used, right? Neuromuscular blockade has to be used, okay? And the patient has to be placed in the prone position. So this is additional things like you have to do apart from placing the patient on mechanical ventilator. And very important point in the management of ARDS is fluid conservative management. Already the lungs are flooded with fluid in patients with the ARDS. So you have to do a fluid conservative management, right? So liberal fluid should not be given. Right, liberal fluids cannot be given in these patients with the ARDS that can precipitate the ARDS. So that is about your type 1 respiratory failure. So how do you manage type 1 respiratory failure? By giving oxygen supplementation. But if it is ARDS causing type 1 respiratory failure, then in such case the patient has to be placed on mechanical ventilator. And if it is other causes of type 1 respiratory failure apart from ARDS, then just oxygen supplementation will suffice and you need to treat whatever is the underlying cause. Then, if you take the type 2 respiratory failure. So, type 2 respiratory failure, it is the disorder where you have the presence of alveolar hypoventilation. Right, where you have the presence of alveolar hypoventilation. Right, so this type of respiratory failure is a consequence of alveolar hypoventilation. So because of the alveolar hypoventilation, there is inability to eliminate the carbon dioxide. Right, there is inability to eliminate the carbon dioxide. So accordingly, what the individual will have? Hypoxia and as well as the hypercarbia. Right, accordingly the individual will have hypoxia and as well as the hypercarbia. That is what you will have in patients with the type 2 respiratory failure. And you see the difference. In type 1 respiratory failure, it is normal carbon dioxide levels or decreased carbon dioxide levels. But whereas here, it is hypercarbia. But regarding oxygen, it is the same. In type 1 and type 2 respiratory failure, there is presence of your hypoxemia. Then, if you observe, what are the reasons or what are the mechanisms of development of type 2 respiratory failure? See, mechanism of the development of type 2 respiratory failure is that, number 1, impaired CNS drive to breathe. Right, impaired CNS drive to breathe. That is one important mechanism. And second important mechanism is impaired strength with failure of neuromuscular function in the respiratory system. Right, impaired strength with failure of neuromuscular function. In the respiratory system. And third important mechanism for the development of type 2 respiratory failure is increased load on the respiratory system. So these are the mechanisms, right? These are the mechanisms for the development of type 2 respiratory failure. Now, out of which, let me discuss what are the reasons for the diminished CNS drive, right? What are the reasons for diminished CNS drive? First and foremost, drug overdose, right? Drug overdose. So, what are those drugs which will cause the diminished CNS drive? That includes the opioids. So, if you take the opioids like morphine, they will cause respiratory center depression, right? They will cause respiratory center depression. And what are these respiratory centers? Respiratory centers, you have that in pons and medulla oblongata. So if you see in the pons, the respiratory centers, they include apneustic center and as well as pneumotaxic center, right? Apneustic and as well as pneumotaxic center. And in medulla oblongata, the respiratory centers what we have is dorsal respiratory group, and as well as the ventral respiratory group. These are the respiratory centers in the medulla oblongata. Okay. Next, second important reason for the diminished CNS drive will be the brainstem injury. Right, brainstem injury. So brainstem, it contains midbrain pons and medulla. So if there is any pontine injury or if there is any medulla oblongata injury, what will happen? The respiratory centers are completely suppressed, right, whenever there is brainstem injury. And once the respiratory centers are suppressed, like there will be diminished CNS drive to breathe, where the individual will develop type 2 respiratory failure. And third important mechanism for diminished CNS drive will be sleep disordered breathing. Right, sleep disordered breathing. Okay, so the example of the sleep disordered breathing will be obstructive sleep apnea. Right, in patients with obstructive sleep apnea, there will be intermittent paralysis, or like the soft palate, it will fall on the respiratory tract during the sleep, and thereby there will be cessation of respiration, there will be apnea. And what will happen during that particular apneic spells? There will be hypoxia and hypercapnia, and that will stimulate the respiratory centers, and immediately there will be an arousal. So sleep disordered breathing, right, that is your obstructive sleep apnea, where the individual can have type 2 respiratory failure. And then in patients with the severe hypothyroidism. So in patients with hypothyroidism, what will happen is there is a decreased thyroid hormone, and this particular decreased thyroid hormone will not be able to stimulate the respiratory centers, because the basic physiology of the thyroid hormone is to stimulate the respiratory centers. And if thyroid hormone is not there, the respiratory centers are not being stimulated, and that will make the individual to develop what is called type 2 respiratory failure. So these are the mechanisms for diminished CNS drive. Now see, we have discussed about the mechanisms causing diminished CNS drive. Now let me tell you what are the mechanisms for reduced strength at the level of the neuromuscular junction. So there are certain scenarios where there is impaired neuromuscular transmission. Right, where there is impaired neuromuscular transmission. Now, what are the conditions where you have this impaired neuromuscular transmission? You will have that in patients with myasthenia gravis. You will have that in patients with the Guillain-Barré syndrome, and you can have that in patients with the amyotrophic lateral sclerosis. So these are the conditions where you have the impaired neuromuscular transmission. Then followed by that, respiratory muscle paralysis. Now, what are the clinical scenarios where you have the respiratory muscle paralysis? Respiratory muscle paralysis is seen in patients with the myopathy. Right, it is seen in patients with myopathy. And this respiratory muscle paralysis can also be seen in patients with fatigue. And this respiratory muscle paralysis can also be seen in patients with electrolyte abnormalities like hypokalemia. Okay, so these are the conditions where you will have respiratory muscle paralysis, and due to which there is impaired neuromuscular transmission. Okay, so these are the conditions which will cause type 2 respiratory failure. Next, how do you treat these patients with the type 2 respiratory failure? First and foremost, the mainstay of therapy for type 2 respiratory failure is you need to reverse the underlying cause. Right, reversing the underlying cause. Then you need to put the patient on mechanical ventilator. But remember this point, mechanical ventilator in the sense, first the patient has to be tried with NIV, that is non-invasive ventilator. Right, the patient has to be tried with non-invasive ventilator. And in spite of placing the individual on non-invasive ventilator, if the oxygen saturation is not maintained, that is the point when the individual has to be shifted onto the endotracheal intubation, right? So first initially the face mask, then non-invasive ventilator, still desaturating, then you need to put the patient on endotracheal tube. So this is the treatment for your type 2 respiratory failure. Having discussed, so type 1 respiratory failure is what? It is due to alveolar flooding. Type 2 respiratory failure, it is alveolar hypoventilation. Whereas if you take type 3 respiratory failure, see, this form of respiratory failure, it results from lung atelectasis. Right, this form of respiratory failure, it results from lung atelectasis. Now, when does this lung atelectasis occurs? This lung atelectasis, it occurs in the perioperative period. Let me explain you this. Right, it occurs in the perioperative period. And that is the reason why this is also called as perioperative respiratory failure. Right, this is also called as the perioperative respiratory failure. So, why this lung atelectasis occurs first of all? See, for suppose, if the individual is being placed on general anesthesia for major surgical procedures, right, if the individual is placed on general anesthesia for major surgical procedures, under the influence of general anesthesia, the lung, it gets collapsed. Right, the lung, it gets collapsed. And during the surgery, the patient is placed on the mechanical ventilator. Right, during the surgery, the patient is placed on the mechanical ventilator. And once the surgery is over, once the patient comes out of this anesthetic effect, the lung which has been collapsed, it should recover back. That should what happen? That should happen normally. But in these patients with type 3 respiratory failure, this recovery does not take place. The lung will be in a state of the atelectasis, right? And there will be decrease in the functional residual capacity. Right? After general anesthesia, there will be decrease in the functional residual capacity. That will lead to the collapse of dependent lung units. So the question is, why there is lung atelectasis? Why it is not recovering? Because after general anesthesia, there is decrease in the functional residual capacity, and that will lead to collapse of the dependent lung units. And that is the reason why lung is not recovering back after the effect of anesthesia. That will happen in patients with the type 3 respiratory failure. Then, how do you treat these patients with type 3 respiratory failure? Okay, first and foremost, you have to see that the patient changes the position, right? Atelectasis can be treated by frequent change in positions. Right, frequent changes in the position. Number 2, chest physiotherapy is very important. Number 3, upright positioning. Number 4, you need to control the incisional pain, right? You need to control the incisional pain or the abdominal pain, right? Next, non-invasive ventilator, right? Non-invasive positive pressure ventilator. This also will be useful for reversing, right? This also will be useful for reversing the regional atelectasis. Okay, so this is about the treatment of type 3 respiratory failure. Next, followed by that, type 4 respiratory failure. So, what is the pathology for the development of type 4 respiratory failure? This form of the respiratory failure, it results from the hypoperfusion of the respiratory muscles. Right, this results from hypoperfusion of hypoperfusion of the respiratory muscles. So you have to understand that how much of the cardiac output will go to the respiratory muscles. In a normal individual, respiratory muscles, let me tell you, they consume, they consume less than 5% of the total cardiac output. Right? In a normal individual, respiratory muscles, they consume less than 5% of the total cardiac output. But in those patients with shock, but in those patients with shock, they often experience the respiratory distress. They often experience the respiratory distress. Okay, and why? Because in patients with shock, the individual has the hypotension, the individual has the hypotension, and because of which there will be decreased perfusion to the respiratory muscles. There will be decreased perfusion to the respiratory muscles. And because of decreased perfusion to the respiratory muscles will suffer with hypoxia. And because of this particular hypoxia, there will be anaerobic metabolism within the respiratory muscle. And that will lead to the development of lactic acidosis. That will lead to the development of the lactic acidosis. So, in these patients with type 4 respiratory failure is due to hypoperfusion of respiratory muscles. Why there is hypoperfusion? That is secondary to the development of the cardiogenic shock. Then, how do you treat this type 4 respiratory failure then? Intubation and mechanical ventilation, that is the mainstay of treatment. Intubation and mechanical ventilation. This intubation and mechanical ventilation can allow redistribution of the cardiac output. Can allow the redistribution of can allow the redistribution of the cardiac output. So once it allows the redistribution of the cardiac output to the respiratory muscles, once it allows the redistribution of the cardiac output to the respiratory muscles, that will improve the oxygenation to the respiratory muscles, and thereby there will be improvement in the strength of the respiratory muscles. So that is about the treatment of the type 4 respiratory failure. Now, you have to understand that in all the forms of respiratory failure, either you take type 1, type 2, type 3, type 4, mechanical ventilator requirement is must if the severity of respiratory failure is more. Then what is that you have to know and you have to understand, that is, what is the care that you have to give to mechanically ventilated patients. So these patients on mechanical ventilator, they have to undergo daily spontaneous breathing trials, right? See, first of all, you have to understand the pathophysiology of respiratory failure. That is very much essential for optimal patient care. And you should also recognize the patient's readiness to be liberated from the mechanical ventilator, right? And several studies have shown that daily spontaneous breathing trials can identify patients who are ready for extubation. But again, it is not all the patients you have to do this spontaneous breathing trials. I will tell you, right? What is the criteria for SBT, that is spontaneous breathing trial? I'll tell you. So, all intubated, mechanically ventilated patients should undergo daily spontaneous breathing trials. Now, by doing these spontaneous breathing trials, we can assess the readiness of the patient for extubation. Right? We can assess the readiness of the patient for extubation. Now, the question is, who are the candidates for spontaneous breathing trial? Let me tell you. Number one, if oxygenation is stable. Right? If oxygenation is stable, that is, if PaO₂ by FiO₂, if it is more than 200 and PEEP of the individual is less than 5 centimeters of water, right? Oxygenation is stable. That is one of the criteria to take it as a candidate for SBT. And if suppose, if cough and airway reflexes are intact, right? If cough and airway reflexes are intact. Next, there is no vasopressor agents or sedatives being administered, right? There is no vasopressor support, right? Or there is no sedative support to the individual. These particular group of patients, they have to undergo a daily spontaneous breathing trials. Then we will be able to make out whether the individual is ready for extubation. Now, the question is, what does the trial consist of? See, this trial consists of a period of breathing through the endotracheal tube without ventilatory support. So, what you have to do in the trial is, the individual will breathe, right? But how this individual will breathe? With the help of endotracheal tube itself, but without ventilator support. Right? Without ventilator support. That means the individual should be placed on the continuous positive airway pressure, right, at around 5 centimeters of water. Okay, right? Or the individual with the help of endotracheal tube has to be placed on the T-piece, right? Has to be placed on the T-piece breathing system. And when the individual is placed on open T-piece breathing system, For how much time you have to place the patient on TP's breathing system? That is for nearly around 30 to 120 minutes, right? So this is what the trial consists of. Okay, you have done the SBT. When will you consider the individual is ready for extubation, or when will you consider SBT is declared as failure, right? So when is it considered the spontaneous breathing trial is declared as failure? Number one, for suppose if the respiratory rate, if it is more than 35 per minute during SBT for more than 5 minutes, it is considered as failure for SBT, and oxygen saturation of the individual is less than 90%, heart rate of the patient is more than 140 per minute, right, or 20% increase or decrease from the baseline. Right, and systolic blood pressure, it should be less than 90 millimeters of mercury, and there should be an increased anxiety or diaphoresis. So if these parameters develop during SBT, then SBT is declared as failure, right? Then SBT is declared as failure. Now, when can the patient be extubated? For suppose at the end of spontaneous breathing trial, none of the events have occurred, right? None of the events have occurred during spontaneous breathing trial. Then the patient can be extubated, right? Then patient can be extubated. But up to 10% of patients, they develop respiratory distress after extubation and may require resumption of mechanical ventilation, right? There is almost chance of reintubation in 10% of patients. Now, see, endotracheal tube, it is not like a tube which can be taken by the patient, right? It is very painful to the individual, right? And thereby the synchrony can miss between the mechanical ventilator and the patient. So in order to reduce the pain, you have to give analgesics and you have to see that the individual is sedated, right? Now the question is, which particular sedatives and analgesics are best? Okay, which drugs are mainstay of therapy for analgesia in mechanically ventilated patients? That will be opiates. Right? Opiates are the mainstay of therapy for analgesia in mechanically ventilated patients. And if you take the sedatives, which sedatives are preferred? That is non-benzodiazepine sedatives. Right? Non-benzodiazepine sedatives are preferred. Since, why not benzodiazepine? Because benzodiazepine sedatives are associated with worse patient outcome. That is the reason why non-benzodiazepine sedatives can be used. Next, you have to remember one important clinical entity called as post-paralytic syndrome. See, in certain group of individuals on mechanical ventilator, we give neuromuscular blocking agents, right? And what are those neuromuscular blocking agents? These neuromuscular blocking agents, they include cis-atracurium, right? Cis-atracurium. Cis-atracurium is used to facilitate the mechanical ventilation in patients with profound ventilator dysynchrony. So in those individuals who has profound ventilator dysynchrony, in those individuals you have to give this cisatracurium, right? See, actually you are providing sedation for synchrony, but despite optimal sedation, if there is dysynchrony, you have to place the patient on the neuromuscular blocking agents like cisatracurium. Now, whenever you use this agent like cisatracurium, may result in prolonged weakness. Right, may result in prolonged weakness, and this prolonged weakness, it is a myopathy, right? It is a myopathy known as post-paralytic syndrome, right? Which is known as post-paralytic syndrome. For this reason, neuromuscular blocking agents typically are used as a last resort when aggressive sedation fails to achieve this patient ventilator synchrony. Then you have to give this neuromuscular blocking agents like cisatracurium. Next, coming to monitoring in the ICU. Now, because you see, the respiratory failure and circulatory failure, they are very common in critically ill patients. So, monitoring of respiratory and cardiovascular system is undertaken frequently. The gold standard for monitoring in ICU patients, it will be arterial blood gas analysis. Right, it will be arterial blood gas analysis. Right, and what all parameters you check in this? pH, PaO₂, right, PaCO₂, then even oxygen saturation. So all these can be analyzed in the arterial blood gas analysis. So with arterial blood gas analysis, the two main functions of the lung, that is the oxygenation of the arterial blood and elimination of the carbon dioxide, it can be assessed directly by doing your arterial blood gas analysis. Okay, next. So arterial blood gas analysis is an ideal way for monitoring the patients in ICU and who is on the mechanical ventilator. Next, the another way for assessment of oxygenation is the pulse oximetry, and this is the most commonly utilized non-invasive technique. And what is the principle of the pulse oximetry? See, pulse oximetry, you know, like it takes the advantages of differences in absorptive properties of oxygenated and deoxygenated hemoglobin, right? This pulse oximetry, it takes the advantage of differences in absorptive properties of oxygenated and as well as deoxygenated hemoglobin. Okay, so what is the difference? At a wavelength of 660 nanometers, oxyhemoglobin reflects light more effectively than does deoxyhemoglobin, whereas reverse is true in the infrared spectrum. So based on this particular principle of wavelength difference between oxygenated and deoxygenated hemoglobin, the pulse oximetry work, right? Next, having discussed about how do you monitor the ICU patients, one is invasive method, that is ABG, and non-invasive method is your pulse oximeter. Now the question is, does pulse oximeter measures arterial and venous blood oxygen saturation? Now, because you take arterial pulsations, the pressure within the artery is high, it produces the phasic changes in the intensity of the transmitted light. And the pulse oximeter is designed to detect only light of alternating intensity. So this feature allows distinction of arterial and venous blood oxygen saturation. So your pulse oximetry it is mainly testing the arterial oxygen saturation, right? Why? Because the arterial pulsations, they produce the phasic changes in intensity of the transmitted light. And the pulse oximeter is designed to detect only light of alternating intensity. Where do you have that alternating intensity? Within the artery. This feature allows distinction of arterial and venous blood oxygen saturation. So, your pulse oximeter measures mainly the arterial oxygen saturation. So, this is about your patient on mechanical ventilator and the various types of respiratory failure. So, if you see some of the questions on the topic of respiratory failure, all of the following types of respiratory failures are correctly matched except type 1 respiratory failure hypoxemia, type 2 respiratory failure hypercapnia, type 3 respiratory failure atelectasis, type 4 respiratory failure perioperative respiratory failure. So, in type 1, yes, it is an acute hypoxemic respiratory failure due to alveolar flooding. And type 2 respiratory failure, yes, there will be hypercapnia, and that is due to alveolar hypoventilation. And type 3 respiratory failure, it is a perioperative respiratory failure where there is atelectasis of the alveoli. But type 4 respiratory failure is due to cardiogenic shock. Right, it is due to cardiogenic shock, right? It is not perioperative respiratory failure, it is secondary to hypoperfusion of the respiratory muscles. So, if you see this overall table, type 1 respiratory failure, you have hypoxia. Type 2 respiratory failure, you have hypoxia and hypercapnia. Type 3 respiratory failure, perioperative from atelectasis. And type 4 respiratory failure, hypoperfusion of the respiratory muscles in shock. Next question is, false statement about type 1 respiratory failure is decreased partial pressure of oxygen, decreased partial pressure of carbon dioxide, normal partial pressure of carbon dioxide, normal AA gradient, that is alveolo-arterial gradient. Let me tell you that in patients with type 1 respiratory failure, they will have hypoxia, normal carbon dioxide, and as well as they can also have decreased carbon dioxide. But they will not have normal alveolo-arterial gradient. There will be increased AA gradient. Right, there will be increased AA gradient. So that is what is your type 1 respiratory failure. Okay, next question. In ICU setting, patient suffering from which of the following respiratory pathology is most predisposed to carbon dioxide narcosis? So carbon dioxide narcosis, in the sense there is hypercapnia within the individual. The options are motor neuron disease, asthma, emphysema, bronchiectasis. So you see in these patients, in early stages, they will have type 1 respiratory failure. So when there is type 1 respiratory failure, they will have decrease in carbon dioxide. But as the severity progresses, right, as the severity progresses, there will be increase in the carbon dioxide. But in patients with the motor neuron disease, right, where there is impaired muscular activity, that is impaired respiratory muscle activity, from the starting of the disease itself, the individual will have hypercapnia in patients with motor neuron disease. Whereas in asthma, emphysema and bronchiectasis, there can be decrease in carbon dioxide. And why there is decrease in carbon dioxide? That is because of increase in respiratory rate. There will be tachypnea, and that will cause carbon dioxide washout, and that will cause the hypocapnia. Next question is, in type 2 respiratory failure, there is low PaO₂ and low PaCO₂, low PaO₂ and high PaCO₂, normal PaO₂ and high PaCO₂, low PaO₂ and normal PaCO₂. Let me tell you that in patients with type 2 respiratory failure, you will have hypoxia and as well as the hypercapnia. That is what you will observe in patients with type 2 respiratory failure. Next question. Type 3 respiratory failure occurs due to hypoxemia, inability to eliminate the carbon dioxide, lung atelectasis, hypoperfusion. As just now we have discussed, in patients with type 3 respiratory failure, you will have perioperative respiratory failure, and that is secondary to lung atelectasis. So the answer is C. Next question is, type 4 respiratory failure occurs due to alveolar flooding, inability to eliminate the carbon dioxide, lung atelectasis, hypoperfusion of respiratory muscles. Remember, alveolar flooding, you will have that in patients with type 1 respiratory failure. Inability to eliminate the carbon dioxide, you will have that in patients with type 2 respiratory failure. Lung atelectasis, you will have that in patients with type 3 respiratory failure. Hypoperfusion of the respiratory muscles, you will have that in patients with type 4 respiratory failure. So the answer is D, that is hypoperfusion of respiratory muscles. Okay. So this completes the discussion of this very important topic, that is respiratory failure. Thank you very much.